You're watching the Wellness Hour, news that makes you healthier. I'm Randy Alvarez. Today's topic, interventional pain management. If you are in pain or a loved one is in pain, you have to hear what my first guest has to say. He's an interventional pain management specialist. In fact, he is the founder of the Society of Interventional Pain Management Physicians. With us, we have Dr. Manchikanti. Dr. Manchikanti, welcome to the program.
Thank you. It is a pleasure to be here and let people know what we are doing.
Okay, good. Now you have 14 locations spread out. Where are your locations?
My main location is in Paducah, Kentucky, and my partner's main location is in Evansville, Indiana. Then we have multiple locations in Indiana and Kentucky, including Louisville, Hopkinsville, Madisonville, Owensboro. We also have one location in Illinois, Marion, Illinois, and then one location in Tennessee.
Today's topic, one of the reasons we invited you on the program is for this show, most people are afraid of surgery, right?
That's correct.
Fusion surgery especially. And we're talking about maybe possibly how to avoid that in the future. We should also mention, you've written medical text. I told my team here, he's written the two most boring books for a lay person, right? And I'm reading, I'm going, I don't even understand what this is about. So this is for doctors.
These are for doctors, and that is a very well-published book, and it is selling quite a bit.
You've written like 14 books or something.
Total of 14 books, right. And I have written about more than 500 articles, peer-reviewed articles. I have conducted a lot of randomized double-blind controlled trials, and we have written multiple guidelines. So now we have a definition for interventional pain management and a specialty designation. And we also have membership on Career Advisory Committee, which actually regulates in each state what is covered and what is not covered.
Okay, good. And just about everything we're talking about today is covered by insurance.
Yes.
Medical insurance.
Except the regenerative medicine.
Does it cost more money to go a guy like you, head of a society?
Actually it is a lot cheaper to go to me.
How? Why?
Because we're not doing the mistakes, and I have extensive experience, so it is easier to confirm the diagnosis and go to the treatment rather than play around.
Okay.
So that's why it is very important when you choose a interventional pain physician, where you go and how they treat you. One of the things you need to know is that, is this doctor certified? Is he a doctor have proper training, like fellowship nowadays? In olden days, when I was doing, there was no fellowship training.
Fellowship is basically after medical school and you go to specialized training?
Fellowship is even after that. Residency is the next thing. Medical school, then you have 4 years of residency.
All right.
Then fellowship is 1 or 2 years.
Okay.
We also offer fellowship training in our own program.
In your centers, all 14 of your centers, you're offering all the new stuff, all the new proven stuff, I should say, for pain relief and stem cells. You're also doing.
That's correct.
That's a hot topic.
Our focus is on the physician-managed practice. Every patient is seen by a physician in our practice.
Okay.
And then offer the current, proven, acknowledged treatments and following all the rules and regulations established.
So let's start with typical patients. We'll start with the people, and since 70% of your practice is low back pain, or back pain, I should say, we're going to talk a lot about back pain, and we'll talk about shoulder and knee and neck and things like that. So who's the typical patient that you see?
Well, these patients can be vary from somebody who hurts only once a month, but it can be very disabling, and they want something to be done. Somebody who can't play the golf, they want to be able to play golf. Or somebody with very serious problems who has had pain for a long time, has been to multiple doctors, has tried various things, including surgery, and about to be disabled or already disabled. So we get all types of patients.
Now, who refers you the patients? So the primary care physicians, the spine surgeons, who is sending you patients?
All of them send. And sometimes
neurologists?
Patients, all types of doctors. So.
Now, do they need a referral? To see you, or can they call you directly, like one of your centers?
They can actually call directly, but it is better to have a referral. That way you will be able to get all the records pretty easily.
Okay.
And you don't have to duplicate the work.
Okay.
And the physician won't be upset that his patient is seeing someone else. So if you go and ask the physician, they will refer without any problems.
Okay. Now, Today we're not going to talk a lot about the pain medications. Maybe we're going to talk about how to wean off some of those pain medications. But we're going to talk about, we'll start with injection therapy for shoulders, back, knees, things like that. And then some of the things you're doing, implantable devices and nerve blocks and spinal cord stimulators and things like that. So let's start with injection therapy. Who does that work best for? And what are you putting in there?
Well, injection therapy is not like the injections you are receiving, but this is a specific injection. I can show you on a mannequin if you want me to. So.
All right, so what are we looking at here? Is this
So
the lower part of the spine?
This is the lumbar spine, and this is what you feel when you press in the back. So the various types of injections are given here based on the pain, source of the pain. Actually, we do a lot of diagnostic blocks to find out where the pain is coming from. I'm not sure public knows it, or you may not know it either, but if you go to a doctor with your pain, we can only make a diagnosis after you had MRI, nerve conduction studies, physical examination, everything. In only about 15% of the patients. In 85%, we cannot make a diagnosis.
Okay.
So we can resolve that issue in another 80% of the patients by doing what is called diagnostic blocks. Like we put a small needle here and do the facet joint block. We can put an epidural injection here or epidural injection
like
here.
On first day, just to see if that's where the pain is coming from?
It will be the second day, second visit. First visit, you are assessing the patient and talking to get to know the patient. It is very important to know the patient. If you don't like a doctor, don't go to them. If you don't like them, don't continue the treatment. So it is a shared decision making. You want to get to know the patient. I'm kind of old philosophical type of person. I need to know the patient. I want to talk to the patient, and I want to know the patient. I want to talk to the patient. Majority of the times, I don't even read the patient's chart. That may look abnormal.
Just get to know them.
But first, I want to talk to the patient. And if you talk to the patient will give you the diagnosis in majority of the cases. And that's why I call it myself old-fashioned, because then I look at what the investigations are showing and confirm what we are suspecting, or we were right or wrong. And about 95% of the time, we are right.
Okay. So when this person comes in with low back pain, and you're going to do injection therapy. So let me get this straight. I mean, it's most of the back pain we're talking about is something is pushing or rubbing against the nerve.
No, not necessarily.
Okay.
That is called the disc herniation. That is mechanical pain. You are talking about mechanical compression.
Okay.
So that is not the major cause of it. Disc herniation is easy to diagnose because it presses on a nerve. The symptoms are very easily identifiable, like your pain goes down into your leg like an electric shock all the way into the foot.
All right.
Whereas majority of the problem where you have a problem is low back pain. It is deep aching, throbbing, and there is no disc herniation. That is where the whole issue comes. So in those cases, we go ahead and first do the physical therapy and conservative medication, all those things. And after that, we do the diagnostic blocks to find out where the pain is coming from. Once we rule out certain structures, we will go ahead and give a different type of treatment. Or if we confirm, let us say with facet joint pain, if we know that facet joints are causing the pain, we go ahead and treat those with
So what the facet joints are where on this spine model?
The facet joints are the facet joints.
There. Okay.
So
and
these
so what,
are
they're
all,
rubbing together? Or what do they do? I mean, where's the pain coming
they
from?
develop arthritis. It's just like your shoulder, knee, or elbow. They develop arthritis, they develop inflammation, and then they start hurting.
So you inject the area. I interrupted you, but you do a test to inject the area.
Right,
and live on the spot, they start feeling better sometimes?
Right, they should feel immediately. Actually, we check them immediately after we do that, if they are responding or not. If they get 80% relief, then we don't do anything else.
Okay.
We send them home. They come back after a month or so. Then we reevaluate how much relief they have had, and then we will do the second block. And this time they should get longer relief than the first one.
Like 6 months, half a year?
The average relief with the diagnostic blocks is 3 weeks with the first block, about 6 weeks with the second block.
Okay.
And then we can do a therapeutic facet block if patient wants a simpler procedure, or if they are okay, we can go ahead and do what is called a radio frequency, where we put the heat on it, so it blocks the stimulation of the pain fibers.
So the signal doesn't go to the brain,
right?
And you don't feel
correct.
The pain.
Right.
Okay.
But it regenerates and it comes back after 6 months. Average is 6 months, but it can last in people a year or so. I had a patient, she had relief about 18 years until she died. So that can happen, but generally known treatment results are about 6 months to 1 year. With the nerve blocks, you can get 3 to 6 months. Sometimes you can get years with
So
that.
is this a big problem? Like, for example, I mean, you're in 14 locations, 3 or 4 different states. Are there like more than 500,000, millions of people that are in pain that don't have to be? What's your hunch?
There are many people, they are in pain, they don't know what to do, and the doctors, many of the times, doctors are very careful and they try not to send them to advanced treatments, and they try to manage them, and that is how they get into different types of medications.
So the primary care physician is usually the first person. They give them some meds to decrease inflammation.
They send them to physical therapy also.
Okay, physical therapy. So if that has failed, then they see you.
No, they sometimes send them to the orthopedic surgeon or a neurosurgeon if they have a disc herniation. But if a primary care physician thinks that there was nothing operable, then they send those to us. Now, when the patient goes to the neurosurgeon or a spine surgeon, if that doctor thinks that there is nothing to be operated, then they send them to us too.
Okay.
So essentially, if we get these patients sooner, the first visit is ours, then we can manage them much better. We can direct them appropriate physical therapy, appropriate medication, behavioral management, and then they can get a lot better.
So when you take, let's say, a construction worker or just a retired person or the golfer, as you mentioned, or the grandmother or the mother of 4, they can't bend, they can't do this. On certain people, you give them these injections, right? And for some people, they're back, even though it may only last for 6 months, but they're back to function, back to exercise, is there benefits there?
That is the main goal of our pain management, interventional pain management. In some circumstances, we cure them, but most of the times our goal is to improve the function so they can enjoy the life. For some people, just dressing itself is the most important thing.
Okay.
Like spinal stenosis, for example, it's also called, symptoms are related to called shopping cart syndrome. When you are going shopping, you are hold on to a cart, so your back is better.
Oh, really? So leaning forward helps
get you out of pain. Spinal stenosis, right.
Okay.
But whereas when you are on the checkout line, you don't have the cart any longer. You start hurting pretty bad, and it goes down into the legs.
So what do you do for that?
So that is called spinal stenosis. So we can do the nerve blocks and injections for that, but there are also other mechanisms. You have complicated surgery, but if you have moderate or mild symptomatic stenosis, we can do a interspinous prosthesis. As here, these are the spinous processes.
Okay.
We put a titanium prosthesis here and here, wherever there is stenosis, and then it helps the patient when it prevents this movement. So pain is when you go like this.
So it keeps, it's like the nerve is being pinched in a way?
Yes, yeah. The spinal canal.
So this implantable device kind of opens it up.
That's correct.
Takes pressure off the nerve.
Yes.
Is that right? Is that, and you call that what?
Interspinous prosthesis, or the trade name is Superion, the one we use, but there are a few others too available.
Is that right? And that works for low back pain? What are some of the other things you're doing for back pain?
It is mostly for the leg pain more than the low back pain. In spinal stenosis, your major problem is called neurogenic claudication, where when you walk, your legs hurt and they go numb and you feel like that heavy.
Okay.
Whereas when you sit down, pain goes away. So it is called neurogenic claudication.
Okay.
So that part is the one which really helps with this part.
What about sciatica?
Sciatica is the disc herniation, as we were talking. When multiple nerves are involved, they call it sciatica. It is a outnumbered or outdated name.
Okay.
We call radicular pain, radiculitis.
The public still calls it sciatica?
Many people call it sciatica.
That's
that is a common name.
So I need to change it from that. Okay, but so how do you treat that so-called, as the lay people call it,
so sciatica, that essentially means, as I was explaining to you in the before, that is the disc herniation itself. It is a mechanical disc herniation, or it could be a chemical irritation. Either one, that is where we do the injections, epidural injections. You can put a small needle into different areas, like if it is in the low back, we can do the what is called interlaminar epidural. That is the traditional epidural everybody has known for years. Or we can come on the side and do the transforaminal epidural. Or we can go here and do what is called a caudal epidural. So when we do that, we inject two types of substances. One is a local anesthetic, other one is a steroid. Some people do steroids routinely. We don't in our practices, because I have shown that in multiple studies. I have conducted about 12 randomized controlled trials, that local anesthetic alone itself can help you as well as with steroids. Very few patients do need steroids, so we use them in those cases.
And what kind of steroids are you giving them?
We are using, there are two types. We can use depomedrol, methylprednisolone, but my preference is called celestone. It is a betamethasone. It is a depot steroid where it stays supposedly where you put it in for a long time.
Okay.
That's why it's called depot steroids.
So there's a lot of people that are in pain that don't have to be. People put it off. You know, we were talking on the phone. I said, my next door neighbor, or across the street, this guy's been in pain. He has insurance. He's been in pain with his shoulder when I met him a year ago. And now today he's walking around holding his shoulder all the time. And I'm saying, well, why don't you go in and at least get, after talking to you, I said, at least get looked at by an interventional pain management guy. You have insurance, get it injected. No, I'm going to let it work itself out. Then you told me you also have a neighbor, that smart guy, that is doing nothing.
There are many people do that. Like this neighbor you were mentioning, he can develop capsulitis, adhesive capsulitis, like a frozen shoulder. If you keep trying to protect it, and then it goes, then their neck start hurting. At that time, when it is too late, they go to a surgeon, and then we find something in the neck, something in the shoulder, it becomes too late. So
if you can get a guy like this early, it's I don't want to call it a quick fix, but in a way it is. Get a guy like that out of pain.
That is, you can get them out of pain, you can give the injections and put them through an exercise program. And a lot of times these people don't even need the repeat injections.
Does it hurt?
Injection?
Yeah, I mean, is it painful?
Well, injection is just like a needle, like you take injection.
But do they complain like it hurts a lot, or not really?
Some people do and some people don't, especially if the people were on a lot of pain medications, and then they program their mind that this is going to be an extremely painful procedure. Then they're not very happy with that when we are doing. So what we do is, for patients, when we are doing the spinal procedures, we give them sedation. We do that at no extra cost. And majority of our procedures are done in a surgery center or office suites. So we give them appropriate sedation.
And you're doing this when you're injecting, I guess you're looking at it under some sort of scope?
Yeah, we are looking under fluoroscopy, under X-ray machine. And
so you're looking at like a monitor as you're putting in the needle?
That's correct. That is extremely important. Nowadays, especially for spinal injections, if you do them without fluoroscopy, you don't even get reimbursed.
Okay. So low back pain, injections, the shoulders. What about knees?
The knees are the same thing. You can do them, knees, you can do them injection under fluoroscopy, ultrasound, or even blindly, because I'm pretty old, so I used to do them blindly before. I don't do them blindly any longer. Knee injections are pretty easy and safe. And these are the patients, let us say you have a lot of knee problems and then injections don't help, and they're recommending surgery for you. That is the time you can also look into the stem cells or PRP injections.
Are you seeing good results with the stem cells for knees?
Stem cell, yes. The results are pretty good. Knee is the most studied organ in the body with the stem cells, and it has been shown to be very good results.
Okay.
In fact, 60% of the patients have avoided total knee surgery. The same way with our back injection.
60% of the patients that maybe they were even told they need surgery, don't need surgery now.
Actually, they were scheduled for surgery.
Is that right? So 6 out of 10 people scheduled for surgery could cancel their surgery.
The only problem is that insurance does not cover that.
The stem cells.
Right. But with the injections also, the results show that about 60% of the patients can avoid surgery.
Is that right? So is your challenge, because look, I mean, you are the creator of this interventional pain management specialty, but is your challenge getting people just to come in early? Like when the pain is starting, you're 3 months into it, 4 months into it, 6 months into it, get something done.
On average, when I looked at my data, patients don't even come to me until 18 months after pain starts.
Is it the men are the worst or the women are the worst? Because men put things off.
Both are pretty much the same. We didn't find much difference in there, how long they have had pain, because women do make decisions for men. So.
Okay. Now the other thing is, on YouTube, and we'll put at the bottom of the screen, but you have great instructional videos. I mean, and they're dummied down. I learned a lot about all the different areas of the spine from watching. I probably watched about an hour of your videos. Very nice. Do most of your patients look at those videos before they see you?
Some of them do. Not all, but some do.
Because some people, they don't even care the mechanism or how it works. They just want to be out of pain.
Right.
That's
all they say that.
Okay.
What are you expecting from me? They just say, I don't want to be hurt anymore.
So let's talk about some of these now, the next level up. Whether it's spinal cord stimulators, nerve blocks, implantable devices. We have a couple over here. So where do you want to go now?
Well, we talked about the nerve blocks a little bit, and they can be done in the neck also, the radiofrequency neurotomy. Then there is also another procedure called percutaneous adhesive lysis. Like you develop a lot of scar tissue after the surgery, we can put a catheter and try to relieve the scar tissue and send the medication to where the problem is. It is called targeted delivery with a catheter.
And this is an implantable device?
No, it is just a regular device, nerve block. So, and then patient goes home that day, and it can help in many patients. Now, when all of these fail and patients already had surgery or not candidates for surgery, we look into either a spinal cord stimulation or intrathecal infusion system. Both are external devices.
What is a spinal cord stimulator? And we're short on time, but what is it?
Spinal cord stimulation is an implantable device. We put it in the spine. It is like a pacemaker for the spine, pacemaker for the heart. It is pacemaker for the spine. So it stimulates the nerves.
Electronically stimulates a nerve?
That's
and what,
correct.
Like numbs them or interrupts the signal?
No, there are two types of fibers in the spine which carry your impulses. The small fibers are the ones which are responsible for pain. Large fibers are not. So these go and stimulate the large fibers, which is a pleasant stimulation. So it kind of cheats and the gate is closed. That is how.
So you don't get the signal to your brain that the pain.
From the small fibers are blocked. The door is closed, the small fibers are blocked. Now they're also saying that there are a lot of neurochemicals released and it can help in many other ways. But that was the original theory, that gate control theory, Melzock and Wall. They said that in 1965.
Okay. So what other type of implantable devices are you doing?
Other implantables is the intrathecal infusion systems, where we put the device in your body. It gives you small amounts of morphine or any of the other drugs like Dilaudid, fentanyl. There are many drugs and many combinations we can deliver on a regular fashion. So those help. The way we choose which one is good for you, if you have a regional pain, if it is just in your back and legs, we go for a stimulator. But if you have neck, mid-back, low back, and multitude of problems, then we go for a stimulator.
Okay, so
for a pump, I mean.
People are taking opioids, right?
That's correct. Majority of them
So
are.
you're able to, in this case, instead of swallowing those pills, delivering it right to the pain?
That's correct.
Problem. So it's less dose, half
the dose?
the dose?
Less, like, much less than that. Like if you're taking 100 milligrams, say 1 milligram per day would do it.
Is that right? So 1 milligram rather than 100 milligrams?
That's correct.
So logically, why doesn't everybody do this? It's a more effective way for the right candidate?
Yeah, it has to be a right candidate. It is an expensive procedure. And
but
also,
insurance covers it.
Insurance does cover it. And again, you have to have refills every 2 months. Whereas spinal cord stimulator is even better, where you don't have to have anything done once you have that implanted. And many people are on extremely low doses of medication if they are. And the problem is that these people are suffering with multiple issues. If they just had a low back pain, they don't take anything, they're fine, they don't even come back to me until they have a problem or just say hi once in a while.
Okay. Now, for some of these people, is it like a miracle?
Yes.
Like they're back to work, back to exercise?
Oh, when you try a injection or a stimulator, trial stimulator, they say that, oh, it is miraculous. I just want it right away. I want the permanent one. So.
Now, we should mention too, your daughter works in one of the practices. She's a medical doctor, pain management. Is that right?
She works in 3 clinics I work in.
Now we're short on time. Couple of minutes left. What about head and neck pain? What are you doing for that?
The headaches are one of the commonest problems, as we know. Everybody has a headache because of many reasons, but most of the headaches, what we can help are related to the headaches which are coming from the back of the neck. It is called occipital headache or cervicogenic headache. Also sometimes the facial pain related to trigeminal neuralgia. But most commonly they are missed. They are treated as migraine and they don't even respond. But their source of the pain is coming from the...
Here we have this model right here. So this is the neck.
This is the neck. So their source of the pain is in the top joints. These are the occipital nerves. This is where they form.
So something is pushing on those nerves?
No, they're just inflamed.
Inflamed, okay.
So the facet joints, which are, especially when you have whiplash, you did a lot of shows on those kinds of. So when they have whiplash, the commonest problem is the headache. So this is the cervicogenic headache. We can block those nerves or do the radiofrequency neurotomy, and patients do much, much better, and then they don't have to take many of the medications they are taking.
So people with headaches, the headaches go away?
Headaches go away, and even if they are, they are pretty minor. So.
We're out of time. So people, we've talked about implantable devices, we've talked about stimulators, lots of different things. Final message though, somebody watching this, they're at the early stages of pain, but it's been a long time. I mean, 6 months, a year, 18 months. You say it's 18 months before people do it. What's your advice to them? Well, and they're afraid of doctors maybe.
Go to the physician, whomever you feel comfortable, and get the proper care. And you have to choose a proper physician, as I said, and make a shared decision making and get better much faster.
Should you look for, do you have a bias? Look for an interventional pain management physician?
Yes, just not an interventional pain. Anybody can call themselves, but it is a well-trained interventional pain physician who is going to stick around in the practice for some time.
Are they called board certified or fellowship trained?
That's correct. Board certified or fellowship trained. And you can check the reputation. So.
Pain management.
That's correct.
And that's
IPM,
that's what you want to see. And you guys know all the new stuff.
Yes, we keep up with the regular stuff, and we also try to project the most recent modalities of treatments, and we recommend physician-oriented practice where physicians are in control of the practice.
Okay, good. Well, Doctor, I want to thank you for coming on the show. We're going to have you back, and people need to look. If you don't see this, I'm sure you'll have it on your website. We'll give that to you, plus on wellnesshour.com. But we're doing a whole segment with you, a full half hour on stem cells for back pain, neck pain, knee pain, shoulder pain. So thank you for coming on the show. Good stuff.
Thank you.
You've been watching the Wellness Hour, news that makes you healthier. I'm Randy Alvarez. For now, I wish you could help.
Thanks for watching the Wellness Hour, the leader in medical news with your host, Randy Alvarez, the authority on health issues.